looks like we are right at our starting time. We will go ahead and get started. Hello, everyone. My name is Kyle Bishop, and it's my pleasure to be able to kick us off on the 6th session of our Student Forum for Mental Health, tackling the unfunded mandate. Jessica, if you don't mind going to the next slide, please. Just a recap of the previous sessions that we've covered is displayed up here. If you missed any of these and would like to get a copy of the recording, please feel free to reach out to me, Kyle Bishop, kbishop@pcgus.com, or just post a message in the chat and I can get you access to see some of the previous ones. A reminder, we do have an Ed Plan showcase coming up on September 10th. So that'll kind of go through and give us a little bit more on that. That's fine. And I'll jump right into our presenters. And Dan Wisman will be kind of heading off the little bit about our two presenters. So Dan, I'll turn it over to you.
Hi, thank you, Kyle. Yes, we're very happy today to have Dr. Melinda Hollinshead, otherwise known as Mindy, and Jessica Rod here today to talk about this important topic. Mindy comes to us with over 25 years of experience in the public health administration. For many years, she was running the school's Medicaid program in Arizona. She's one of the preeminent experts in this area, is on many national advisory committees and boards. So I think we're going to get a very nice perspective of where free care is in the country today. Jessica has worked for PCG for many years. She's a senior consultant here. She's leading up our efforts to do school Medicaid claiming. Just to tout her horn and PCG's horn, we've claimed over $7 billion worth of funds for schools for their school-based program. So it's been very successful. Jessica has seen everything that can go wrong, that works on a very practical level, and she's going to talk us through, what the necessary components are to handle free care. And we'll get right into it. And Mindy, take it away.
Okay. So good morning, everyone. If you're in the West like me in Arizona, it's morning still. Otherwise, good afternoon if you're where my colleagues are on the East Coast. So I'm going to provide a sort of quick session overview, kind of talk to you about what I hope that you're going to get out of today's session, and then go through some of those high-level points, as Dan mentioned, in terms of kind of where we're at nationally, what we've seen in terms of momentum around free care expansion, a little bit about what that looks like in the current environment under COVID, and then what we think that means in terms of sort of access to mental health services specifically. And then I'm going to turn it over. We'll do a little bit of question and answer after that, and then turn it over to Jessica to talk more specifically about some of the things she's learned in terms of implementing this at the state level or district level. So one of the things about the background on Medicaid and schools program is historically, as we know, Medicaid only paid for health services that were included in IEPs for kids who are enrolled in Medicaid. And what that meant is that about 80% of low-income school-age children received their health care through Medicaid. So that's about 37% of school-age children. And so the opportunity for districts to get reimbursement through kids that had IEPs on Medicaid, that's about the numbers that represents. But what that really means is it's only about 1% of total Medicaid spending in the country. And in most state budgets, while Medicaid represents a pretty significant part of most state budgets, the school-based services program is a very small part of those agency budgets. And it's one of the reasons why I think we find sometimes it's hard to get some traction on issues that are important to schools and around school-based Medicaid when the Medicaid agency is tackling other issues. And that's been especially important during this period of COVID when they've had many other priorities. What we saw in 2014 was a change in a federal policy. So CMS changed their stance on what was called free care. So prior to 2014, schools were not able to get reimbursed for services they were providing in schools that were outside of an IEP or that were to the general education population. In December of 2014, they sent out a letter reversing that policy. And initially, I think the reaction was, for those of us who are in this environment, everybody thought this was going to be a great way to move forward with bringing some additional reimbursement into schools. Pretty quickly, that momentum kind of started to subside a little bit as people really looked at what that was going to mean in terms of the necessary requirements to meet all the Medicaid rules for that population outside of the IEPs. And so we didn't really see a lot of movement around free care for the first couple of years that it was available. And one of the things I'm going to be talking about is why we think that momentum changed around free care over the last couple of years. But what we see now is as states are moving in that direction, what it's doing is creating some new opportunities to enhance the role that Medicaid can play in terms of bringing in a sustainable source of revenue to schools, how schools are able to expand their ability to draw down federal dollars to support the services that we know they're already providing to students, both in special education and in their general education population. And that's been especially important in terms of how states are addressing the need to expand access to mental health services. And in many cases, states don't have any mandate in terms of where the money that comes back from school-based reimbursement, what has to happen with that. Frequently, it goes to sort of the general fund for a school district. So it leaves open a lot of opportunities for how to use that to bring in additional providers or technology or things like that that can help them meet these goals of expanding services. Some states do have some specific requirements. Colorado has some requirements just as an example around it going back into the needs of students around health services. So it's important to understand what the particular requirements within your own state are. So seizing this opportunity. What we saw a couple years ago, as I said, initially, there wasn't a lot of movement around free care. But what happened was we started seeing a shift in momentum nationally around safe school initiatives. I think most people in school districts are familiar with. About 2 summers ago, we started seeing the Safe Schools grants. There was an influx of money into states to try and look at how do we address safety in schools, and that then translated into conversations around access to mental health services for students. It's interesting because free care didn't come about as a discussion where people just said, we need to start thinking about free care. It was more as a response to, we need to figure out how to address school safety. We know that an element of that is addressing access to mental health and behavioral health services. How do we do that in a way that can be sustainable within our schools? Because many of these grants coming from legislatures were one-time funded grants. And so it was how do we think about a sustainable way to do that? And so looking at free care expansion was a way to think about how to do that in a sustainable way and expand access to services. So what we know is that in traditional IEP-driven models, mental health services usually only account for about 10% or sometimes less of what the overall reimbursement that's coming into a school for IEP students. Those are traditionally the therapy services, speech therapy, physical therapy, occupational therapy, but more so those first two that are driving reimbursement. But when we look outside of the traditional IEP environment, that's where we start seeing mental health services and nursing services actually having a much greater impact in terms of reimbursement for schools. Still going to be significantly less than what we see in an IEP model because those kids have defined medical necessity already in place. And so the reimbursement is always probably going to be a little bit higher than when you expand out into the general population, but it does allow for some additional revenue, particularly in the areas of mental health and nursing services. So states have been able to kind of harness that momentum around the discussion on how to address school safety and mental health to work on expansion of free care services. And part of what that national momentum did as well was influenced a better partnership between CMS and the states. So what we've seen is CMS become a very good, productive partner with states who are working to try and expand their programs under free care. Good dialogue between the two. CMS has really been working with states to try and help them figure out how to mold that into their existing programs and their existing statewide Medicaid program to be as effective as possible. And so there's several models that are being considered in terms of how you design a school-based Medicaid program that can reflect that uniqueness, can look at what those specific policies and requirements are within each state. Some states are more heavily invested in managed care that have to address those issues. Sometimes it has to do with provider qualifications. These are all things that I'll get into in a little bit more detail. But as states are facing the challenges related to COVID, and what we know are going to be budget shortfalls at the state level for Medicaid, for the schools, they're also looking for ways to build that relationship between the school and Medicaid, because we know that the need to support kids coming back into schools around the mental health and the nursing is going to probably increase even more than what we've seen in the past. A lot of kids are going to come back with real needs to be able to access providers who can help them with either things that they dealt with during the time that they were out of school, or just the stress and anxiety around coming back to school in the environment that we're likely to see that occur in. So next slide, Jess. So I'll just spend a second on this. This is about sort of a high-level map in terms of where we're at with free care expansion. So you see 10 states in here in dark green. Those are states who've actually, even previous to the pandemic, had already started moving forward with free care, had gotten SPAs approved by CMS to do the expansion, and are in the process of moving forward in one way or another with implementation of the program. There's a couple light green states there that are that have that in process with CMS. They haven't been approved yet. A couple states that they were fortunate that the language in their existing school-based state plans didn't require a state plan amendment in order to move forward with free care. They were able to make some other changes at the state level to be able to do that. But I want to note that while a lot of states there look gray, what we know is while they're not actively engaged at this point with CMS, they are in many cases in many of these states. Arizona is an example. Virginia is an example, Ohio is an example of having conversations internally at the state level around what it would take to think about free care expansion. Can they build a coalition within the state to make that happen? So even though they're not, they didn't make it onto this map in terms of meeting the requirement for this map of being in some place around CMS discussions, it doesn't mean that some of these states aren't having internal discussions around this. So CMS Trends and what that means to states. So like Medicaid as a whole, which there's no one size fits all model for Medicaid programs in general. When you work in the field that I come from, we say if you've seen one Medicaid program, you've seen one Medicaid program. They all look different, you know, in terms of their reliance on managed care, in terms of what they allow, what their state options are, because there are certain services that are federally mandated. EPSDT services for students or for kids are mandated by the federal government, but then there's a lot of state optional services, and so it really depends on the state. And so that's true for school-based programs as well, because they have to be modeled to some degree off the state program. So CMS has been working with states to approve changes that are then unique to each state. So and some of this just has to do with where the state wanted to go with their expansion. So Massachusetts and Colorado, as an example, worked to do sort of a full scope program change to include free care. They expanded it to the whole population. They've added some providers. They've done all of the services. One of the things we have seen CMS recommend is that approach to going to a broader base language for state plans. It used to be that they were very specific to school-based programs, and you had to define the services and the providers specific to the schools. We've seen CMS in conversations with many states recommend that they elevate that language and just note that school is the place of service for services that are already approved in their overall state plan, and for providers who are already qualified to provide those services within their state to eligible enrolled students. So that's what we saw in Nevada. They elevated their state plan to have almost basically a paragraph that addresses specifically schools, but for the most part, it lifts it to the broader state plan language. Some states have worked to do some eligible provider expansion, especially in the areas of mental health, or to just focus their program on expansion around nursing and mental health services. So those free care services wouldn't be expanded necessarily to the entire service categories, but to mental and behavioral health or nursing services. And what we've seen is CMS enhance their flexibility around some of this stuff in the face of the public health emergency with respect to COVID. So especially in the area of telehealth, when schools and all of this happened suddenly in March, we saw CMS, put out a lot of guidance to states, Medicaid programs, enhancing flexibility to be able to try and meet these needs. So in terms of expansion, so one of the things that I think is important is to remind ourselves that free care is not the creation of a new program within school-based Medicaid. For a long time, we talked about it as such a separate thing that it really started to trip states up as they were thinking, I need to create, I have my school-based program for IEP services, and I need to create this new free care program. And that's really not the case. Free care is really just an expansion of the student population for whom you're eligible to receive reimbursement for services that you're delivering. It's the same program, essentially. It's just expanding that. It's an extension of your existing program to those new population of students. CMS is, as I said, encourage states to strike those covered services and instead include the coverage of their EPS, DT, and Medicaid eligible state optional services. And just note that it's services being delivered in a school. They've worked with states to include some new providers into the school-based program through this process, but that really requires an assessment of the comparability of the eligibility requirements. So there's been a lot of discussion nationally around school-based psychologists, school-based counselors, school-based social workers. Those are actually provider types that in some cases states actually had in the past and had to remove at one point. Not quite 10 years ago, CMS was looking at that because they didn't meet the requirements to be able to operate in the community as well, which is a CMS overall Medicaid requirement. And so many of those providers were taken out of school-based programs. CMS has really worked with states, I think, in response to knowing that if we want to expand access to mental health services for schools, we have to recognize the providers that are providing those services in the school setting. And so they've really worked with states to be able to assess the comparability of that. You still need to be able to demonstrate that in some way the certification requirements that those providers have in a state that frequently are certified by the Department of Education also meet the CMS or state Medicaid requirements to be able to operate in some way in the community. So looking at some comparability there. So the reimbursement considerations, for states that are operating a fee-for-service claim methodology, this was the case for Nevada, then claims are submitted, they go through the process within the Medicaid agency to review the claim. If it's eligible for payment, they're paid. It goes back to the provider or the district in this case. And it's relatively straightforward. So they were able to lift that state plan up. They looked at that new population of eligible Medicaid enrolled students, where their medical necessity was being documented in ways beyond the IEP. Some new services that they added, and then looking at the opportunity to provide new providers into the program to enhance that direct reimbursement. For states that have cost settlement methodologies where they're receiving payments throughout the year for services that are being provided, but those are usually interim payments, those are not strict fee-for-service payments, or in a couple of states they can be a methodology that is paid out once a month based on previous cost settlements. And then at the end of the annual term, they do a cost settlement and cost reconciliation to what they received in payments throughout the year against what it actually cost to provide those services. Those states, there are some additional considerations when you talk about free care expansion. You need to look at additional codes within the random moment time study to be able to accurately capture their time spent on those services that are both IEP and non-IEP direct services. So the percentage of time those providers are spending on those non-IEP services, free care expansion services. You have to look at how to determine the eligibility rates, Medicaid eligibility rate for students with and without IEPs, and how to include that in your calculation. But CMS has really worked with states to develop cost settlement methodologies that allow them to address the addition of those free care services and how to capture that time appropriately. In either case, it's important to remember that the documentation that's required to support claims to be submitted for Medicaid reimbursement is going to be the same. So even when you get outside of the IEP environment, having those qualified providers, having a way to document medical necessity, and having a way to track and document the services that are being delivered is still going to be as important as it was under the IEP program. So moving forward, I think that what we've seen, as I've talked about, is this national momentum. It's been going on for a couple of years. That's helped states move in the direction of expansion and ways to create that sustainable revenue source to be able to meet some additional needs around mental health specifically. But I think what we're going to see is that that momentum is going to, at worst, continue, at best probably increase, as COVID has impacted schools and mental health and Medicaid delivery of services. So I think what we're going to see is actually a building on the momentum that we had in place even before, because we're going to see, as I said earlier, the importance of supporting that mental health for students. It's going to be more essential now than ever before. We're going to address many things, from kids being out of school for as long as they were, but as well as the experiences that they had while they were out of school and the anxieties that they have as they're entering back into school right now, in most cases through remote learning, and what that looks like for them, as well as when they have to go back to the physical location. I know, as a personal anecdote, my daughter actually, my fourth grader now, started online learning this morning. So we were trying to manage that and woke up with a lot of anxiety around that. And she's, probably more technologically facile than I am, but still creates some anxiety for them. So I think that as we see this, as schools reopen, all these lessons that we're learning and all these things that we know about free care and these things that Jessica is going to talk about in just a couple minutes, around what we've seen in terms of why is this worth it? What are the things you have to really do to make this work? And what are some of the experiences that we've seen in places that have moved in this direction are going to be especially important to us to be paying attention to in the upcoming months. So with that, I think we're going to turn it over to some Q&A for this first section. I mean, if there's still things that you want to understand about sort of the overview and the momentum and the opportunities before we move into those specific program elements, I'm happy to answer some questions around that.
Great. Thanks, Mindy. I do have a question just to kind of kick us off with. How would I know if school-based counselors or psychologists in my state might be eligible to claim in the school-based program?
So that's a great question. It's actually something that, and again, it's really going to be state specific in terms of the actual requirements, but overall, what you're really looking for is a combination of things. I mean, you have to understand, depending on the particular service type they're looking at, whether there are federal requirements and regulations around their licensure or the certification. But in the case of mental health and nursing services, it's really more dependent at the state level. So it's really going to be looking at what state licensure requirements are. Are the providers you're talking about certified within the state, or are they actually licensed? If they're licensed in the state, they're licensed providers that currently aren't in your program and you want to add them, that's probably going to be less of a heavy lift. They probably meet the Medicaid requirements. If they're certified, which is what we often see through school-based providers, they're frequently certified through a process with their Department of Education certification. And so then it's really looking at what does the Department of Education require in terms of education, in terms of clinical hours, those kinds of things, supervision, to get that Department of Education certification, and how does that compare to any non-licensed providers that may be operating in the broader Medicaid community. So do you have some non-licensed certified providers working in community mental health centers that those centers can then bill for the services and time of those providers to Medicaid? You may be able to come up with a comparability argument around that. So those are the kinds of things that you should be looking at to the specific state requirements.
Great, thank you. Another question, if my district wants to kind of move forward what would be next steps that we can take? How will we proceed?
So I think at the district level, what you want to be looking at is you want to be turning to anyone that has a pulse on what's happening at the state level. And so sometimes that's looking to your Department of Education, if that's who administers the school-based program, and asking some questions around whether there's a dialogue currently going on around free care. If it's a Medicaid agency in your state that oversees the program and there's a contact there. In many states, there's a vendor. One of the things that we do is operate as a statewide vendor in several places to help states administer aspects of the program. And so frequently, if there's a statewide vendor, they'll be plugged into any conversations that are occurring around that expansion. And I think it's really important for districts to ask to be involved in those conversations, because the policies that are put in place, especially around additional documentation or documentation outside of the IEP, when we're talking about 504s, behavioral intervention plans, health plans, it's important for schools to have a voice in how they currently document those services and what that's going to need to look like going forward to meet the Medicaid requirements, so that as the program is expanded, those considerations are taken into place when they're putting together those policies and procedures. But it's really looking to the state agencies or a vendor, or in some cases, in some states, it can be some provider advocacy groups that may be pursuing discussions around free care. We've seen that with some of the nursing associations or other groups that are looking at those issues.
Excellent. And I got one more that came in. How do the licensed behavioral providers feel about putting a diagnosis on a student? Will that diagnosis impact any future job opportunities?
So typically what we see is it's not so much that those providers are being asked to diagnose a student. What we usually see in both the case of IEPs and in the case of other types of plans is to be noting in there what the diagnoses, and frequently there's more than one that a student has, and those have often been something that they're coming into the school environment with that diagnosis. And what they're really doing is recommending the services on the basis of that diagnosis and on the basis of the evaluations that the student has at the school level, recommending the services that they'll need to be able to access their education. As we know, it's sort of the idea is accessing their education in the least restrictive way. And so it's really about supporting that. It's one of the things that makes the recommendation of services by providers that are operating in the school a little bit different from sometimes the community providers, is their focus is on what needs to happen to be able to support that student as they're in the school environment. So they're really taking that diagnosis that's probably already in place and then recommending those services.
Excellent. Jessica, I think we're okay to move on to the next step, and we'll probably pick some of these up as we get through your slides. Thank you, Mindy.
All right. Thank you, Mindy. And Kyle, Mindy, just quick, everybody can hear me okay?
Yep, we can hear you.
We hear you well.
Thank you. Just double checking. So I think Mindy did a wonderful job of providing the high level, big picture. Where are we at a federal level in terms of the policy around free care and mental health services? And I think we're really starting to get into, what might be on your mind, which is, okay, I'm in a district, maybe I'm a specific provider. How do I help get this started? Where do we even begin this process? And so I think while we've been working with some districts and some states, we'd like to take a step back and ask three really important questions. One, is it worth it? I mean, I think Mindy did a good job outlining the fact that Medicaid programs, Medicaid reimbursement, while it is available and it is something that would be beneficial to the school districts, sometimes there's a additional workload that comes on with that. And so you need to be able to understand the trade-off in terms of any increased cost or increased work versus the actual reimbursement that's going to be coming through, right? There is a cost benefit analysis that I think is really helpful to dig into. The second component of it is thinking, am I prepared? So while it may seem, okay, we did the numbers, there are additional dollars, we think this will be really helpful to support our students and our clinicians, there are certain components to Medicaid reimbursement where you really have to be in a position where you're prepared to provide any documentation required to support those claims in the event of an audit. And anybody who's been through an audit knows it can be very detailed. They can go back many years. And so having those particular procedures and processes in place to say, okay, not only did I submit the claims for reimbursement and we got the dollars back into the school, which was great, but I know that in the case if somebody came in 7 years from now and asked, hey, can you provide me all of the supporting documentation around this particular student and this particular service, it would readily be on hand. The third question, which I think is starting already to be asked, is like, how do I move this forward as an individual, as a school district? And we can talk a little bit more in terms of the details that Minnie was already getting into about how you can affect change at your local level to get your state to move forward, or if your state's already moved forward, how do you actually implement? So digging into, is it worth it? So Minnie really explained that there's the possible expansion areas, and we're not thinking about free care as a new program. We're thinking about expanding your current school-based Medicaid reimbursement program to include new areas that would be available. So one area to think about is new services, and there are some programs in the US right now where even for IEP students, counseling services are not reimbursable. There are quite a few states that say we're only reimbursing for speech, OT, and physical therapy, and beyond that, you're on your own for that. So there might even be an opportunity not only for general education students, but even your current special education reimbursement program, counseling services might be something that's new. Crisis intervention. A lot of times the services have to fall within the scope of a plan. A crisis intervention is not going to be something that's planned. And so these can be things like suicide threat, risk assessments, just general maybe grief counseling that comes up for a student. And we think with COVID, this is going to be something that there's an uptick because so many students have been thrown off of their normal behavior patterns. So things that are a little bit more ad hoc in nature under a free care expansion program could potentially become reimbursable in your state. And then a lot of the evaluations and psychological testing, again, there are states that reimburse for this already for their special education student populations. We're thinking about, okay, now everything that happens outside of special education, those tests and evaluations could now become reimbursable. The next component to think about is a new student population, right? So we've been repeating, yes, special education, and this is because this is what the program has looked like previously. But when we're looking at expanding our free care services, we're really looking at saying, hey, we're going beyond special education and really moving into the general education population. For some states, they've chosen to say, we still feel really comfortable about having some sort of plan to back up the referral or the requirement of the services. So you're looking at students that have 504 plans, or perhaps they have behavior intervention plans. And we think those are more common than we initially think, especially with the IEP students, again, because within IEPs, it's a very small percentage of the population that's receiving the psychological counseling that's currently reimbursable. But this really expands what we're thinking about in terms of the different types of student populations we can look at. And the last thing to think about are the service providers, the actual clinicians. There's been mention of the school counselors, the school psychologists, and the school social workers. And again, in some states, they have to be licensed in order to be Department of Education certified. But in some states, they don't have to be. And that's fine. They can still deliver services in a school. What Medicaid is going to say is, let's see if we can find some matching requirements within our realm to see if we can make those providers reimbursable. And I would say federal Medicaid, CMS, has been very accommodating in terms of working with states to understand there's a shortage of providers across the board in terms of services that need to be delivered to students anyways. Why are we trying to restrict what's already being delivered and the providers that are already there? And let's try to find some ways to work together to get services to the students and then dollars back into the schools. I think something that we've seen in a lot of the state plans that have been approved, so those are the state plans at the Medicaid agency that get sent to the federal government, marriage and family therapists. And so you're thinking about not only the individual student, but the way that they actually interconnect with their family or with the outer greater communities. So you're looking at more group counseling type situations. And again, that's expanding the provider base that you're really looking at. So again, there's new services, potentially new students, and potentially new service providers that you could be looking at in terms of reimbursement. So to give some hard examples, because there have been a few states that over the past few years have finally gone through the process and gotten their state plan approved by federal Medicaid, and they're starting to implement this in the schools. One of the states that's gone first is North Carolina. And so they are a state, like Mindy mentioned, that they're not only a traditional fee-for-service state where they're submitting services on an ongoing basis for reimbursement, they're also doing that annual true-up at the end of the year. And so we've gone through one full cycle of everything to include all of the new providers and all of the new services. And what they found in the state of North Carolina is that on average, the district's total Medicaid reimbursement went up by 25 to 35% in the first year, where they were able to include all of these new mental health providers and all of the new mental health services. In each district, it's going to be a little bit different. It depends upon if they actually had these providers on hand. Some districts are maybe a magnet program where they are actually known for having a strong mental health or behavioral health program. So they would have attracted more service providers, more students. So maybe their reimbursement was higher than some of their peers. But again, overall in North Carolina, the first year shows 25 to 35% increase in your total overall Medicaid reimbursement, not just the reimbursement focused on mental health services. So for most states, when we're doing the analysis, what we've seen thus far is there's a range anywhere between 15 to 15% to 50% increase in the overall Medicaid reimbursement. And the reasons for that are just dependent upon what the current plan is for that state. So if we have a state that is a more restrictive or a smaller program that's really just focused on those core therapy services of speech, occupational therapy, and physical therapy, well, when you expand it out to include mental health services, you've now got a variety of student populations that are coming on board, a variety of new service providers that are coming on board, and there's quite a bit of services that you weren't capturing previously. So those will be states that are on the higher end of that percentage, while states that have a more expansive program already may see that 15 to 20% increase, which is still sizable in some districts. So how do you actually assess whether or not this is worth it? So one thing is to think about how can you quantify the number of services that are actually being delivered. And when we've worked with some districts, this is maybe more challenging than you would think it would be, because if we are thinking about different departments and different types of providers now being eligible, you may be using different systems. You may be required to do different types of documentation. And so finding a singular place where you can bring that all together and say, okay, we know for a fact we're delivering 10,000 services throughout the course of the year might be a little bit challenging. For IEP students, that's probably easier because most districts already have a system of some sort and you're kind of providing those numbers on an annual basis for a variety of reports. But thinking about 504 students, behavior intervention plan students, those might be new areas where maybe it's not as easy as you may think. Newly covered students. So getting a number of how many students actually have 504 plans, how many students in your district actually have behavior intervention plans. Again, because these programs might be managed by different departments within a district, there's probably the possibility that there might be silos of data out there. And so really thinking about having to interact with each of those departments to say, hey, look, we're trying to do an analysis. We need to figure out how many students are on each of these types of plans. It's not unusual too, if a program is small enough or if a certain subset of students, hey, it's not a really big population within our district, you might still be doing this on paper as well. And so getting that paper documentation to kind of understand who has what type of plan, how many services are being delivered, it might be a little bit more time intensive to quantify that. I think the last thing is really looking at the new covered service providers. This might be the easiest thing to kind of get a number on. Usually this is coming from a business office or an HR department to say, hey, we have X number of school psychologists, X number of school social workers, and that's great. I would also recommend people look at including any contracted providers that they have. So either folks that you're bringing in, or maybe a student traditionally would have been sent out of district. Maybe they're your new telehealth providers. You're working with another firm that's actually providing telemental or telebehavioral health services. So make sure to include those folks in your numbers to kind of decide, okay, how how large of a population am I actually looking at now in terms of new service providers? So it's that combination of new services, new students, new service providers, and then kind of putting it into an equation and figuring out, okay, we think maybe we've got 50% new services, we're going to have 20% more students, and we're going to have 20% more service providers. We can kind of ballpark it, maybe it's a 35% increase, right? You can do some rough numbers, but there's definitely ways that we've helped districts in the past to do a more specific calculation. Medical necessity, right? So we're moving on from, okay, I did all my numbers. I think, maybe it's a 25% increase. Maybe it's up to 50. I think those dollars are worth it. Let's get started. So now you take a step back and think, okay, now that I know what the dollars are, am I going to be ready to actually be able to pass an audit if it were to happen about the service submission and the claim submission of these services? So one of the things to look at is medical necessity, and Mindy brought this up. So Medicaid is great because it will reimburse for services that are deemed medically necessary. And this is where we get a little bit of tension within the education realm, because a lot of times we're thinking, okay, well, within a school, we're delivering these services because they're educationally necessary, and that's true. But they're usually also medically necessary because the student would need them in the outside of the schools to really incorporate it into their improved health. So when we're thinking about medical necessity, districts will have to ascertain what they're going to have on hand to say, yes, we had a Medicaid qualified practitioner. So maybe it's somebody that has a license, it's a licensed psychologist, it's a licensed social worker. And then there's some sort of plan, a plan of care that prescribes the services that are actually being delivered. So those could be the IEP, they could be the IFSP, 504 plans, behavior intervention plans, and there's other medical plans that districts have currently that they use to address things like medication administration. So it's not to say it has to be one of these plans in particular. You may have other forms that you're already using within a school district, and that's fine. It's about making sure that it's very clear about the types of services that are being prescribed. And then the person who actually reviewed that documentation in order to say, yes, I meet Medicaid requirements, I've reviewed it, and then we've got a plan that says, yes, the student needs these services for a medical reason, not just an education reason. There are some states that utilize physician orders or physician authorization. So it'll be a separate process in which not only will you have an IEP or a plan of care, but then a document will also be signed off by a physician or another licensed practitioner of the healing arts. And so that will go in line with your specific state Medicaid plan to say, if there are certain services that need to have a doctor's sign off, essentially, to say these services are medically necessary. So the next component that we talked about was service documentation. So the services are usually being rendered and they're definitely being documented. It's just about where are they being documented. And again, because these programs, these students might be managed by different groups within the school. There might be different heads of departments that are managing behavior intervention versus 504 versus your IEP population. So it's really about figuring out, okay, what is each set of providers actually doing in terms of their documentation? Where is it being housed? And would we be able to actually retrieve those documents or retrieve those notes in case we were being audited, right? So it's not unusual for schools to have a variety of systems that are happening. It might be multiple electronic systems. You might have one system that's tracking everything. You might have some people doing electronic documentation, and then some folks are on paper, and they feel like that's safer because they don't want their clinical notes going into a system. So it's important to understand where the documentation is happening, how it's being housed, and then how you would be able to retrieve that if you needed to in the case of an audit. I've definitely had providers tell me they keep their notes in the trunk of their car because they feel like that's the safest, and that's everybody's individual choice. But you need to be able, if you're a district and you've submitted a claim for reimbursement to Medicaid, you'll need to be able to get those documents. The last thing we'll hit upon, and this is not the last consideration, but this is probably the third largest component of what's being asked for within the free care realm, is parental consent. And this is a separate parental consent from saying, hey, you can deliver the services to my student. This is a parental consent that says, you as a district are authorized to release my student's information to bill a third party, in this case, Medicaid. This is a very familiar form within the special education realm already. We know that districts already have challenges around this. Parents can be sometimes skeptical of signing a separate form, especially when it mentions their Medicaid benefits and how that might tie in. The parental consent is an IDEA requirement, so it has been specifically codified within the special education code. However, when states have looked at expanding their free care program, they thought, well, if we're already getting parental consent for our special education students, and we feel like it's a good combination from a FERPA perspective and a HIPAA perspective of making sure we're not releasing information from an education perspective or from a medical perspective that the parent doesn't know about, then maybe we'll just do parental consent for all of the students moving forward. We'll have this one blanket parental consent, and we'll be able to say, hey, if a student has a 504 plan at the beginning of the year, but then we decide, hey, we want to refer them to special education, we won't have to get a separate parental consent form to bill Medicaid if they transition from one plan to another. So this would be thinking about what is your current process if you're currently billing Medicaid for your special education services, and thinking about, okay, what is working with that process, what is not working with that process, how would we need to modify what we're doing, how would we reach out to those additional parents, do we think there's going to be any challenges, and then making sure that the language on the form itself is actually expansive enough that it's not just pigeonholed into that special education perspective, but it's really broadened out to cover all the health services that a student may receive. So we say, okay, I've thought about it. The money in terms of the dollars coming back to the district seems like it's worth it. Am I prepared? I understand there are things I may need to look at. I think we can move this forward. There might be some improvements we need to make, but I don't doubt we can do that. We're ready to go. So as Mindy started pointing out, one of the things we should look at when you're thinking about, okay, how do we move forward, is determining where your state's currently at with their program. So it may be necessary to review your current school-based Medicaid policy manual, and I just go to my favorite search engine, which is usually Google, and type in school-based Medicaid policy manual for fill in the state, Missouri, Nevada. Usually you'll get a link directly to whichever website that it's hosted on. It could be your Department of Education, could be your Medicaid website, and it'll actually list out what your current program is covering. We have heard that in some states the program got expanded and maybe the districts weren't aware, so that might be something to verify off the bat. If the current program and the policy manual says, hey, we know we're still focused on special education at this point, the second step you could do to just make sure you're doing your due diligence is reviewing the current state Medicaid plan. Again, that's a simple search. It'll usually take you to the federal government's Medicaid website, and it'll actually list out everything that's currently reimbursable under your program. We do know there are some states that have allowed services to be expanded and then have decided maybe to hold off on the implementation, the practical components, but at least from a federal perspective, they've got everything covered, and then maybe they're choosing over the course of the next 2 to 3 years to slowly roll it out to the districts, and that's fine. If you are in a state that you've reviewed the policy and there's nothing in there and you don't really think there's anything that says, hey, we're going to address mental health services for general education students, now you need to think about, okay, what are we actually asking for, right? Is it we want new services to be included in our program? Is it we want expanded student population in terms of we know we have a very high population with behavior intervention plans, and we think that would really be beneficial if we could capture those services, submit them to Medicaid, and then get the reimbursement on those services. So then we could cycle that back in and maybe support other programs. And then which service providers do you actually want to include? And again, that goes to looking at licensing requirements. And maybe the answer to this is I want all services for all students, for all service providers. And we're usually a big proponent of that. But then matching it up against the federal Medicaid requirements to say, okay, what do we think CMS is actually going to allow? But I think if you're going to make the ask to the state, you want to ask for everything, and then you can choose to implement in phases. I think the last important thing is to identify the stakeholders. And this is something with school-based programs. They are managed by different departments and different agencies in each of the states. We do work in areas where the Department of Education is the main stakeholder and all of the policy goes through them. There are other states where it's the Department of Health. They own this program. And so if you want any changes to be made, you have to go meet with them. And that's great. I think the one thing to remember is that at the end of the day, all of these changes have to go through the state Medicaid agency. They are the only agency that has the authority to create that state plan, to make any changes to that state plan, and then submit that up to federal Medicaid. So at the end of the day, you can go through your different state agencies, but if it doesn't start with the state Medicaid agency, it's going to end with the state Medicaid agency. So there always has to be a plan in place of how do we get to the Medicaid agency at the end of the day. There are advocacy groups that are out there. I think that's been extremely helpful in some of the states that we've seen free care get expanded. Sometimes it's easier. There might be dynamics between the state agencies that it's not always the easiest for them to work together, but there are certain advocacy groups that have a lot of sway. And if it comes from a particular group, usually they'll be able to get the meeting with whatever agency, or maybe they can get it with the governor's office. So there's really no right or wrong way to do this. And if you can think of advocacy groups that you found very effective within your state, I would say feel free to bring them into the conversation and see how you can work together to really bring this forward to your appropriate state stakeholders. The last thing on here is your district level of your LEA champions. I think this is really, really important. I think that from a federal perspective, we get a lot of feedback in terms of, hey, great to hear from these advocacy groups. We understand that, but we need to know how this is affecting districts on a day-to-day basis. It would make it more tangible for us if we understood like this was really a challenge for schools, or we understood that this would really make an impact for schools. So don't underestimate your own kind of power within this movement. We've seen a lot of different areas where school districts have either built a consortium and then gone to state agencies together to say, hey, we've done some basic analysis. We think there's an opportunity for us to bring in thousands, millions of extra dollars into the schools. We know we're going to need this due to the circumstances that are happening right now. We know this is going to be an ongoing issue. How do we move this forward? And I think everybody knows there's usually a couple of really strong district or LEA leaders you can probably think of within your state that, hey, if you could get them on board, they tend to be the ones, they might not be from the largest districts, but maybe they've worked in the state agencies before, they work really well with the advocacy groups. I mean, collaborate, build your community, and try to work together to get this to the state agencies. So I think that finalizes the information I was going to provide. So Kyle, are there any questions about the specifics around thinking about how a district moves forward with the program?
Yeah, thanks, Jessica. I'm going to give just a couple minutes to see if anyone has any questions in here, but I think you did an excellent job addressing a lot of the questions we had going in here, so thank you.
Great. I would say while we're waiting for questions, that last part, we've seen this expansion come from a variety of places. Sometimes it was the Department of Education making that argument to the state Medicaid agency. There's been a couple of states where the districts have gone to their state legislators and then had the legislation put some pressure on the state Medicaid agency. So any path's a good path to get there. It might just be different depending upon where you are and what the dynamics are within those specific groups.
I'm not seeing any questions trickle in. Oh, a little delay, just got a couple. First one that came out, in school districts for school personnel eligible to provide billable services under Medicaid that are funded by either local or general funds and not federal funds. Are there similar limitations on how positions are funded when billing Medicaid under free care, or has that changed?
That's a great question, and we would say that position has not changed. So Medicaid being a federal reimbursement program, they will not want to reimburse federal dollars with federal dollars. So if you do have staff who are funded with federal grants or federal reimbursement of other varieties, we would probably say that those providers are probably still off limits for reimbursement, but absolutely anything that's funded by state or local dollars, those are definitely still on the table. So I don't think we've seen anything that says for free care, that's, we can do away with that. I still think the federal kind of restrictions on that are still in play.
Yeah, I would agree with that. And also just to add to, because this comes up sometimes as states and mainly Medicaid agencies who don't necessarily understand the school environment as well, sometimes think that there are providers who are providing services to the general education population, and then a separate set of providers who are providing those services to the IEP students. And that's, as you know, if you're from a district, not generally the case. I mean, you have providers who are providing services and they're seeing both kids with IEPs and kids who will fall into that free care expansion. And so it's not necessarily separate sets of providers. And so as Jessica said, the rules around those providers not being 100% federally funded it still apply.
Excellent. Then another question, are the ESE or the special education procedure codes the same as the general education procedure codes, or will those be different in a free care?
That's another good question and a very technical billing question. I love it. The answer is we've seen those codes remain the same and then be expanded to additional codes. So things, if we're going to look at counseling, for example, so there's usually already codes for psychological counseling. You'll see that those will be utilized again. What you may see is then an additional code for crisis intervention, which will be a new service. So I think when you see any new services be added, then you're going to see different procedure codes or bill rates associated with that. But in general, states have really tried to keep the same set because then it just makes the implementation that much easier. It doesn't create a lot of extra work or a lot of extra knowledge or table set, whatever the case may be. So I would say usually what we see is if it's a new service, brand new, never been reimbursed before, you'll see something different. Otherwise, states have been trying to stick to the set that they have so as not to create additional burden.
I think that makes a lot of sense. All right, I think one final note for folks. I've had a number of people ask in the chat for a copy of this presentation. We have been recording this, and this will be available to the public once it's kind of up and online. If you would like a copy of that, please feel free to either just jot your email address into the chat, or if you prefer, send an email directly to me at kbishop@pcgus.com. And I would be happy to send that out to everyone once it's available. With that being said, I think we've kind of wrapped up the questions. So Jessica, Mindy, thank you both so much for your time. We really appreciate you taking the time to kind of share this important conversation with everyone. And as always, I appreciate everyone jumping on and listening to what we have to say. That being said, I'll go ahead and close this off. So have a great rest of your day, everyone. And again, I see a lot of people putting their email addresses in here, so I will be sure to get that recording out to you. Thank you.
Thank you.